burn injuries, some of the most critical, challenging, and intimidating emergencies we face in the field and the emergency department. So whether you're pre-hospital or in the ED, getting fluid resuscitation right is a lifesaver, literally. Why is it so important? Well, severe burns disrupt the skin's ability to hold fluid, thermoregulate, and massive inflammatory changes cause massive fluid shifts. Without early resuscitation, patients can spiral into shock, organ failure, and even death. But don't worry. Today, I'm going to guide you through the essentials of fluid resuscitation, including how to calculate fluid needs, adjust for special circumstances, and avoid common pitfalls. So come on, let's talk trauma. So before we talk fluids, let's talk about calculating total body surface area, or TBSA. Now, these acronyms, it can get confusing, but keep in mind, this is just a tool for estimating the amount of total body area that has been burned, either partial thickness or full thickness. This is critical because we only base fluid resuscitation on the total body surface area burned. So, the rule of nines is an easy way to estimate TBSA in adults. Each major region gets a percentage. The head gets 9%. Each arm gets 9%. Each leg, 18%. Front of the torso, 18%. Back of the torso, 18%. And the perineum gets 1%. So let's give an example. If an adult patient has burns covering the front of their torso and one leg, that's 36% total body surface area. In kids, we have a tool to adjust based on their proportions using a chart called a Lund and Browder chart. But in the field, we're going to estimate the best that we can. Now it's time to talk numbers. But don't let this freak you out. Remember that these formulas are a guide and help us start our resuscitation. So this brings us to the Parkland formula. Now, this formula is the gold standard for fluid resuscitation in burns and is recommended by the American Burn Association. And it's simple. It's 4 milliliters of lactated ringers per kilogram per percent of the total body surface area burned. Now, for example, let's say you have a 70 kilogram adult patient with 36% burns. That's 10,080 milliliters over the first 24 hours. But remember that half of that needs to be given in the first 8 hours post-injury. So we divide 10,080 by 2. Now, depending on the organization that you work for, you may have actually heard of other fluid resuscitation formulas. There's the modified Parkland formula that reduces the volume slightly. Instead of 4 milliliters per kg per percent of total body surface area, it just drops it down to 3. And that some centers use that to lower the risk of over-resuscitation. The consensus formula, which is often used for pediatric or more complex cases, recommends starting with 2 to 4 milliliters per kilogram of percent of total body surface area. And that allows the provider to tailor the amount based on the patient's condition. The key takeaway, always adjust fluid resuscitation based on how the patient responds. The formula doesn't dictate what we do. Our assessment and clinical judgment dictates what we do. So speaking of response and reassessment, let's talk monitoring. The best indicator of adequate fluid resuscitation is urine output. So that means in these burn patients, we should be placing Foley catheters in all of them. For adults, we're going to aim for 0.5 to 1 milliliter per kilogram per hour. For adults under 30 kilograms, our target is actually going to be higher, 1 to 2 milliliters per kilogram per hour. And if we're not hitting those numbers, it's time to readjust the fluids up or down. Electrical burns. Now that's a whole different game. The external damaging can be deceiving. It's the internal injuries that get you. Remember, the current travels from the point of contact through the body, through the path of least resistance until it can find ground. That can take you through muscle, organs, fat, whatever it needs to get through. And we're not necessarily going to see that damage on the outside. These patients are at high risk for muscle breakdown or rhabdomyolysis, which can lead to kidney failure. So here's the tweak. Aim for a higher urine output of 75 to 100 milliliters per hour in adults with electrical burn injuries to help flush out the myoglobin and prevent kidney injury. These patients may also need additional monitoring like CK levels, electrolyte monitoring, and EKGs, as well as a lower threshold for dialysis if kidney function starts to tank. All right, now it's time to talk pitfalls, because there are a few traps to avoid in fluid resuscitation. Number 1, over-resuscitation. Too much fluid can lead to complications like abdominal compartment syndrome or pulmonary edema. This is why reassessing frequently is critical and why we use formulas like the Parkland formula to begin with, because it helps guide our initial fluid resuscitation. Pitfall number 2, forgetting to recalculate. Burn wounds evolve, and so does the patient's status. Fluid needs might increase or decrease during the initial resuscitation period. Stay flexible. Pitfall number 3, neglecting electrical burns. Remember, these patients are going to have injuries that we cannot see, some of which will declare themselves during the patient's resuscitation. If we don't stay on top of those and be aggressive with our fluid resuscitation, monitoring electrolytes, and monitoring EKG, we could find ourselves behind the 8 ball in these patients. So what's the bottom line? Well, for burn patients, fluid resuscitation is about balance. Start with the Parkland formula or whatever version that your organization subscribes to estimate fluid needs. Remember, estimate fluid needs. They are guides. Monitor urine output closely and then adjust based on the patient's response. For electrical burns, don't forget the increased fluid needs to protect those kidneys. Burn care can be intimidating, but you got this. With the right approach, you're giving your patient the best chance at survival and recovery. So thanks for watching, and until next time, stay sharp, stay focused, and keep saving lives. I'm Ben, and this has been another episode of Let's Talk Trauma.